So let's jump right in. You and your partner are dispatched to with the fire department to a park for a male party with injuries from a fall. So you call en route and you head over to the call. And on scene, you find this guy. He's limping on over to you kind of slowly. His name is Tom. He's a 7-year-old male. He was on a run, and basically he fell onto a stump and struck his left chest. He has no other injuries, but he fell, struck his left chest there, complaining of pain and shortness of breath. So Tom here is obviously short of breath. He has an obvious increased work of breathing. He's speaking like 1 to 2 word sentences. He's got this large area of ecchymosis to his left chest when you pull up his shirt, with a pretty severe tenderness to palpation. He's got a decreased left chest movement. His right lung is perfectly clear. However, his left lung is completely absent. You can't hear anything on his left side. His heart rate's 118. His blood pressure is 92/64. His respirations are 30. They're kind of labored. And then his SpO2 is 92% on room air. So, what is your working diagnosis? And honestly, the answer screams at you. It's kind of a tension pneumo, right? And more specifically, it's a closed traumatic tension pneumothorax. So, let's talk about that. So, what is a pneumothorax to start? Pneumo means air, thorax means chest cavity. And pneumothorax thus means air in the chest cavity. And more specifically, it's the presence of air in the pleural space or pleural cavity. There's several types of pneumothorax. These are the big ones that we kind of learn about. Iatrogenic is what happens when you mess up a central line or overventilate an asthmatic, that kind of thing. First, we have spontaneous pneumothorax, right? Usually, you get primary, secondary. Primary is kind of the unexpected unexpected pneumothorax in otherwise healthy patients, right? They're usually a spontaneous rupture of like blebs and stuff like that. The cause of the blebs actually usually unknown, but more than 80% of these appear to have some like emphysema-like changes, despite no history of smoking. So there's kind of a gray area between like primary and secondary. Secondary pneumothorax occurs in individuals with underlying respiratory disorders. So patients who have like emphysema, cystic fibrosis, tuberculosis, lung cancer, pneumonia, those types of things. Basically, the integrity of the visceral pleura is compromised in some way, and that would describe them as and if they get a bleb or whatever, that's a secondary pneumothorax. Um, Primary is basically none of those things are diagnosed, but they could still be there, and that's why that blurring of the two kind of occurs. And then over here we have traumatic pneumothorax, and these are the ones that we generally associate with pneumothorax. So traumatic pneumothorax can happen from punctures from a fractured rib, medical intervention, complication, right? So like an iatrogenic pneumo from access or event or whatever. And then the thing with the traumatic pneumothorax is it usually involves both pleura. We can call traumatic pneumothoraces either open or closed. So a closed traumatic pneumothorax is usually caused by a rib fracture. Basically, there's no penetration of the chest wall from the outside. There's no atmospheric communication from the chest wall. And then you have open pneumothorax, where there's communication, right? So it's a communicating pneumothorax with the atmosphere. Basically, air is drawn into the pleural space during inspiration and then forced out during expiration. And that usually results in a partial lung collapse, fortunately. Both can be described as either simple or tension. So we can have spontaneous or traumatic. We can have primary spontaneous, secondary spontaneous. We can have closed traumatic or open traumatic. And then we can have simple traumatic or tension traumatic, simple spontaneous or tension spontaneous, right? Um, Tension is just tension physiology, right? So you have hypoxemia, increased work of breathing and shortness of breath, hemodynamic changes, and that's the important part actually is the hemodynamic changes, not the hypoxia. Tension pneumothoraces cause hemodynamic changes, right? So the vast majority of tension pneumothorax is from trauma, like almost all of them, and we'll get into why later. But generally, a tension pneumothorax is associated with some form of trauma. So let's look at some anatomy and physiology quick. So here we have the thorax, and in it you have the lungs, heart, chest wall, etc. And it's broken up into 3 separate compartments. You have the mediastinum, which is where the heart, great vessels, trachea, mainstem, bronchi, etc. all sit. Then you have 2 lung compartments. So the lungs are surprisingly big. So the apices extend up past the clavicles, the bases rest at the base of the diaphragm, Then the diaphragm separates the thoracic from the abdominal cavity, which makes it a moving target, right? So at rest, the outer margins of the lung bases rest right around the 10th thoracic vertebra, but they can extend a lot lower during inspiration. And sometimes the difference between like a lung shot versus a liver shot is basically what stage of the respiratory cycle the patient was in, which is always something to keep in mind when you go to like penetrating trauma and stuff like that. So, you've got this moving target. Here we have what's called the hilum. It's basically where the arteries, veins, and main bronchi enter the lungs. There's a pulmonary ligament that also sits there, and that's where, let's see if I can draw on here. The pulmonary ligament attaches down across in here on both sides, and it kind of comes across down in here. So there's pulmonary ligament, hangs out down there. And the pulmonary ligament is basically connects the lung surface with the diaphragm below it. And then it's also the connection point for the pleura. So here are the pleura. Basically, the pleura is one continuous membrane that forms this sealed envelope surrounding each lung. So you have the visceral pleura attached to the lung surface, and then it doubles back on itself at the hilar region, right where we just showed you, and then continues on as the parietal pleura. So I think, especially when I first started, I thought of these as two separate things. Like one's just on the chest wall and one's on the lung, and there's just space between them. But it's one thing. So if you picture like, you know, here's your lung, the pleura comes around it like this and then folds back on itself, and it's like a balloon that goes around it. And then the inner pleura rests on, you know um, you have the two layers that are essentially the one organ, if that makes sense. So then you have also the pleural space. The pleural space is super important for today. So the two pleura are usually in essentially contact with each other, and there's this potential space between them. So they kind of rest on top. Um, in that potential space is the pleural cavity. So what do we mean by potential space? Because that's the area where air gets stuck in a pneumo. It's called a potential space because there really isn't a space there. Everything is really kind of tight in. The only thing between the pleura is a really thin layer of the serous fluid, usually around like 15 to 20 mLs per lung, that's constantly produced and then drained out by the lymphatic system. So this fluid lubricates the membrane and then allows a near frictionless movement as they kind of slide over one another during breathing. But it also creates this cohesive force between the two membranes and prevents separation. The pleural cavity is actually really key to ventilation, and the fact that it's a potential space is really important. It's a potential space because it can become a space. Like you can get air or more fluid and stuff like that in there, but it's not currently a space. It rests against each other, but has the potential to get stuff in the middle. So really the pleura is key to ventilation, right? The lungs passively follow the movements of the chest wall and the diaphragm, right? The lungs can't move on their own. There's no attachments between them. Nothing keeps the lungs connected to the chest wall or the diaphragm except for intrapleural pressure. So interpolar pressure is a negative pressure, right? The average is around -5 millimeters or centimeters of water, but it ranges between like 10 to 3 to 4. Um, and when we call it a negative pressure, but it's technically not. It's a positive pressure, right? It's just lower than atmospheric pressure. And atmospheric pressure is 760 millimeters of mercury, and we know that the atmospheric pressure and the alveolar pressure are equal to each other because we have a mouth and we have a nose, and there's the communication between the two, and they equalize. So we can call those zero because they're equal. So when we say -5, it's not actually -5. We have 760 millimeters of mercury outside, and we have 755 millimeters of mercury between the intrapleural space, which we call -5 because we call the other two relative zero. It's not actually a negative pressure. It's just less than atmospheric pressure. It's subatmospheric. So what makes this negative? Why is it less than atmospheric pressure? And really it all has to do with elastic recoil. So you have the lungs, and these have a tendency to recoil inward or pull away from the chest wall. The lungs want to be tiny. They want to be collapsed. It's their natural state. Their natural state is airlessness in this tiny like little sac. The chest wall, on the other hand, has this tendency to spring outward. The chest wall is held inward kind of against its will. So each one of these pulls on the pleura. So you have the lung that wants to collapse in, you have the chest wall that wants to spring out, and these pull on that pleural space and it pulls on the pleura. And that's what creates this kind of vacuum effect. So at rest, this is actually the only thing holding the lungs open. When there's no air moving, inward recoil pressure of the lung is exactly balanced by the outward recoil pressure of the chest wall, which is this concept is really the key to understanding a pneumothorax. So let's take a look at how we breathe, right? We have atmospheric pressure outside the chest. We have this atmospheric pressure inside the alveoli due to the communication and equalization of pressures with an open glottis. And we have our interpleural pressure at -5. So a breath is triggered, the diaphragm pulls down, the chest wall pulls out, and this pulls on the attached pleura, the parietal pleura, right? And then due to that negative pressure slash vacuum effect, the visceral pleura is also pulled out. So you get chest wall, pleura, parietal pleura, pulled out, which because of that negative pressure is going to pull that visceral pleura with it, which is going to pull that lung with it. And now our pleural pressure goes from -5 to roughly around -8, right? The visceral pleura is attached to the lung. The forces are transferred, and it's called a transpulmonary pressure, and then those lungs open. So Boyle's law, PV or P1V1 equals P2V2, right? Pressure and volume have this inverse relationship. So as volume increases, pressure decreases. When those lungs open due to the pleura pulling on each other, that volume in the lung increases, right? Pressure is decreased from 0, where it was out in the atmosphere, to -2 because we increase the volume, so we decrease the pressure. So now there's a change in pressure from 0 to -2. And that pressure gradient is created. In air, it's like anything else, flows from high to low. So you have this higher pressure outside, this lower pressure inside. Air rushes into the lungs from high to low, usually around 500 mLs or so, and then that pressure equalizes. So we get 0 and 0 again. And then what happens when that happens? You get these stretch receptors and stuff like that that know when that happens, right? We know when we get this equalization, and the muscles release. The pleural pressure goes back to -5. The lungs naturally collapse, and that pressure increases to +1 because of all the extra volume. So we went from 0, -2, +1 because it's squeezing that volume of air out, and then the air flows out because it goes from +1 to 0 in the atmosphere. Literally, that entire system is dependent on the creation of negative pleural pressure, which creates a change in what's called the transpulmonary pressure. So, what happens when we put a hole in it? Let's talk about the pathophysiology of pneumothorax. The jam is that air gets into the pleural space, right? And that happens through a communication with the outside world, like in penetrating trauma, or the lung itself, right? And the problem is air wants to move from high to low pressure. So you have atmospheric pressure, intrapleural pressure, air wants in, right? And will continue to do so until that pressure equalizes. Because it's negative, air rushes in. Jam with that is that negative intrapleural pressure, again, is the only thing that keeps the lung inflated and sticking to the chest wall. So, when that intrapleural pressure becomes 0 or equalizes with the atmosphere, that lung wants to collapse, and it gladly will. So the lung starts to separate from the chest wall when you get a pneumo. It starts to pull itself in. Right? So the first problem we have is this regional atelectasis, and you get this VQ mismatch and hypoxia. And because you get this increased work of breathing, and you get this increased work of breathing because now the chest has to generate even more negative pressure to open those lungs because we don't have that negative pressure that's pulling. You see, we can still overcome it. It's harder to do. We have to pull harder. Pneumothorax, if you don't remember anything else from this whole lesson, right? Pneumothorax is a pressure problem, not a volume problem. The pathophysiology is a loss of subatmospheric pressure, not an increase of volume, right? That subatmospheric pressure was the thing keeping the lung open and pulling on it to breathe. It's a pressure problem. So we have a simple pneumothorax, right? And in simple pneumothorax, the intrapleural pressure is equal to the atmospheric pressure. And good news, right? We can overcome that. We can increase respiratory rate. We can increase our work of breathing, right? It's not like the lung has fully collapsed. So we just need to compensate a little bit, right? You can survive off one lung. Now, if it's closed, air comes in and then back out. If it's open, you can get a sucking chest wound, right? And that exists when air enters the pleural cavity preferentially via this open chest wound rather than the lungs. And usually this only results in a partial lung collapse, right? Generally, it requires a hole bigger than 2/3 the diameter of the trachea to actually preferentially pull air through that anyway. So you get this negative pressure, it pulls air in. You get this positive pressure, it pushes the air back out, right? Atmospheric pressure, you get this pneumo. Um, Atmospheric pressure equals interpleural pressure, and you get this pneumo, right? And the goal, you can just cover that up, and more on that in a minute. So, when does a simple pneumo become a tension pneumo? Eventually, we hit this critical mass of air that makes the intrapleural pressure positive. When this happens, or this usually happens when a one-way valve is created where air can come in but can't escape out. So, with every breath in, you're pulling all of this air. But because that valve effect, right? So you're pulling air, and you get this, you're pulling air and then it covers. So you can't get the air out. You're pulling air and it covers and you can't get the air out. You're pulling air and it covers and you can't get the air out, right? So air enters, the intrapleural space becomes positive, and that's when that lung collapses. It's because the intrapleural space became positive. Um, so the lung collapses, the chest wall comes out, right? And then the air then keeps entering the and the air keeps entering, right? And then the intrapleural pressure rises significantly. And then that ultimately puts pressure on the mediastinum. And more importantly, the right atrium pressure increases. So a normal right atrial pressure is like -2 to 8. And, this added thoracic pressure creates a preload problem, right? So once intrapleural pressure equals the right atrial pressure, there's no more preload and no more cardiac output. And that's how these patients die, right? These patients, pneumothorax patients, die from hemodynamic collapse due to pressure on the mediastinum, not hypoxia. This is what kills tension pneumo patients. Obstructive shock, right? All right. So let's talk about diagnosing a tension pneumo. This is a clinical diagnosis, right? There's no imaging required or anything crazy like that. We in the field can diagnose an tension pneumothorax. So when we talk about simple pneumothorax, right? Tachycardia is the most common finding, right? You get this decreased SpO2. Um, you can get this decreased SpO2, but usually not. Um, we talk about classical findings, right? Decreased breath sounds, hyperresonance to percussion, and decreased raps and tactile firmness. Um, which, by the way, tactile firmness is the vibration of the chest wall that results in sound vibrations created by speech or other vocal sounds. Their voice changes. That's the fancy way of saying their voice changes. Those classic findings are actually really uncommon, but they're classically taught. So, whatever. Tachycardia is the most common finding. And then we get tension pneumothorax, right? So we get like signs and symptoms of a simple pneumothorax. You get profound dyspnea with increased work of breathing, paradoxical chest wall movement, hypoxia, decreased or absent lung sounds, JVD, hypotension, all those things, right? Notice I didn't put tracheal deviation, right? Because, um, you know, it's essentially not seen, right? For the trachea to actually deviate requires such an immense pressure that the patient usually codes first. So I've seen tracheal deviation. I've seen lots of pneumothoraces. And I've only seen tracheal deviation twice, and both of them were on dead bodies. So it's while talked about often and while taught and in textbooks and like every EMT student will say it, it's not actually a common finding and probably not even worth putting on there. Also, keep in mind that there can be a penetrating wound to the thorax, also, which would be a sign of a tension pneumothorax, right? Or an open pneumothorax leading to a tension pneumothorax. So always keep that in mind too. You might have a stab wound. So you can do imaging. There's chest X-rays. You would do like an AP, upright AP with inspiration. You can do ultrasound, right? You're looking for like absence of pleural lung sliding. You can see the pleura move against each other, kind of like between the ribs. It's called anthon in a pneumo, you can't. You can get like a barcode sign if you go into M mode or like a seesaw sign, all this other stuff that ultrasounds beyond the scope of this quick case. Um, but useful, and EMS tends to carry it. But if your agency carries it, I'm sure you've gotten training on it. And then CT scan. You can always do a CT. You probably shouldn't do a CT. You should probably have diagnosed this way before you got a CT, but you can diagnose with a CT also. So talking about management, how do we manage these patients? Really, the goal is to reestablish atmospheric pressure, right? That's what relieves the tension in the hemodynamic issues and allows the patient to reestablish that pleural contact, so they can start to try to, like, breathe better. The eventual goal is to reestablish negative pressure, but that actually requires suction to do. So it requires roughly -8 to pull the lungs open. It requires like -20 to reestablish negative pressure, which is why in the hospital, these patients will get a chest tube and a chest drain and they'll hook it up to suction, and that suction is usually at -20. And it's to reestablish that negative pressure. We're not going to do that in the field. We're just trying to reestablish atmospheric pressure. We're trying to not make the pleural space positive anymore. So, if it's an open pneumothorax, you can put a chest seal on, right? I'm sure we've all seen those. Only if, how I usually do it is if they're breathing on their own or breathing spontaneously, you can put a chest seal on. If they're under positive pressure, so if I'm bagging them, I just don't. Um, you know, usually if the open wound is less than 2 centimeters, they're usually not treated. You usually don't have to do anything. Usually, if you look on the imaging and it's less than 2 centimeters, or if it's less than 20% of a pneumo, honestly, a lot of times simple pneumo patients just go home, or they're discharged, or they're watched right on the floor. Um, these aren't really a medical emergency, so we don't really have to do much for them. Um, One thing we can do if you suspect a simple pneumothorax, or really any pneumothorax, is provide high flow oxygen, right? So oxygen helps the body reabsorb. Um, if you think about it, right, we have 70 or 21% oxygen, 78% nitrogen, and like 1-ish% other. Nitrogen's really heavy and it's really slow to absorb. And if you think about it, the same composition of air that's in the outside environment is now inside the chest wall. Um, got lots of nitrogen in it, right? Nitrogen's heavy, it's slow to absorb. If we give 100% O2, when we replace that nitrogen with oxygen, the rate of reabsorption can be increased sixfold, right? And if it's humidified, it can be increased sixfold. You have to humidify it technically, but if 100% O2 is administered, you can decrease the amount of time it takes to fix a simple pneumothorax pretty dramatically. So I always put these patients on high flow O2. If their oxygen's okay, try to get that nitrogen washed out of the chest wall. Again, if it's an open pneumothorax, we can use a chest seal, right? And that prevents air from entering but allows it to exit. It makes the intrapleural space less positive and then hopefully to zero. And it's usually like the hyphen's the one that I use. I obviously make no money from these companies. That's just the picture I have and what we carry. It's that like 3-channeled one. You can also do like a 3-sided dressing and stuff like that. The TCCC and all these places tend to go back and forth on whether like they use seal versus fully sealed versus it's kind of all over the place. Do what your protocols say and what your medical director wants. Things tend to change there. For tension pneumothorax, you know, even if it started as simple, always be on the lookout for the development of tension pneumothorax, especially if they're under positive pressure ventilation. But really, to treat a tension pneumothorax, it's the same steps we just talked about: O2, chest seals, etc. If they have a chest seal, burp the chest seal, or just dart them on top of the chest seal. Like keep the chest seal, dart them. Because those um, putting on a chest seal, sometimes the air doesn't escape as ideal, and you can build up air, and it can create a tension. But anyway, um, when we talk about tension, really the treatment is the same things as before, and then needle thoracostomy, right? You can also do finger thoracostomy, tube thoracostomy, which is a chest tube. But really in EMS, we're going to talk about needle thoracostomy. And yes, some agencies do finger thoracostomy, but the vast majority stick with needles. So needle thoracostomy is going to be kind of what we're going to talk about. So the goal of needle thoracostomy is to relieve that positive pressure and turn it back into atmospheric pressure. And turns out we really suck at this. Not only were the needles too small originally, but also we can't seem to find the right place to put them. This study here is from 2022. And in this study, not a single paramedic placed the needle in the right spot. Don't worry though, because ER docs also kind of suck at it. This is where they went. So it's not just EMS. Really, when we talk about our landmarks for needle decompression, we have two. We have the second intercostal space, midclavicular line, which is far more lateral than you think it is. So how I like to do that is to find the angle of Louis, which is the sternal angle. So if you look over here, it's right there. That's the angle of Louis, or the sternal angle. That always connects to the second rib, right? So we have first rib, second rib, find that angle of Louis. So I find the sternal notch, I work my way down their chest, find the angle of Louis, attaches to the second rib. I go mid clavicle. So there's clavicle, and then somewhere in there should be your spot. Um, yeah. And then we can also go fourth or fifth intercostal space, mid and anterior axillary line. Um, so to find that, have them hold up their arm. You're gonna go right into their armpit. Um, Honestly, I'm not gonna lie, a lot of this is just ballparked. If you find nipple line or intramammary fold on females, it tends to roughly correlate to where that is. Honestly, as long as you're north of the nipple line or intramammary fold, you're in the safe area. There's something called like the triangle of safety. So if you take their arm, put it up, find the bottom of their armpit, find the mid-axillary line. That's one part of the triangle. Find nipple line or intramammary fold. That's the other part. And then find their pectoral muscle. And that triangle that's created there is called the triangle of safety. And anywhere in there is usually an okay spot to go. It's ballpark the fourth or fifth intercostal space. But those are our two landmarks. How to find them. Keep in mind that this anterior axillary line, or I'm sorry, the second intercostal space is way more lateral than you think. Your clavicle starts here and ends over here. Um, so you'll find people who go really medially here, and what sits there is the aorta and the heart and the mediastinum and stuff like that. Please don't be the person to put the needle in the aorta. Go more laterally than you think. Find actually like the nipple line roughly or the mid clavicular line and go lateral to that. So go more out than you think. And you can look up pictures of all of this online, like videos on YouTube and stuff like that. So now the question becomes, right, now that we know where the landmark goes, what size needle do we need, right? And this paper was really the big game changer here. Turns out lots of controversy over the utility of EMS decompression. This paper basically found out that it was the needle's fault. So this was a comparative study in adults, basically anyone over the age of 15, and a longer 3.14-inch needle compared with a shorter 1.96-inch needle was associated with a big significant improvement in success rate, right? So like literally almost double, it was a little over double, right? It was 83% versus 41% success rate by using that longer needle. So now we know, right, our two locations that we should go, and we know we need at least a 3.14-inch needle, which is where that 3.25-inch needle comes from. Most of the recommended needles for needle decompression currently are at least 3.25 inch, and this is why. So, what gauge should it be? So now we know where, we know what size, what gauge needle do we need? And these guys here looked at swine models and PEA arrest, secondary to tension pneumothorax, and they found that a 10 gauge was better. And then these guys confirmed it. So the conclusion, 10 gauge is better than a 14 gauge, which is why the current TCCC recommendations are a 10 gauge needle that is at least 3.25 inches. So if you don't have those, get those. Not like necessarily those ARDS ones. Those are the ARS needles are the ones I use, and they're the most popular by far. They're made by North American Rescue. I make no money here. They're just the ones I use. But yeah, whatever brand you happen to use, right? Use a 10 gauge, at least 3.25 inch. So what about kids? Basically, these guys looked at kids between 0, 5, and 10 years presenting with tension pneumothorax, and then they recommended a 22 gauge needle, a 20 gauge needle, and an 18 gauge needle, respectively. So, a 0 should get a 22, an 18 gauge for a 5-year-old, and then a 20 gauge for a 5-year-old, 18 gauge for a 10-year-old. Anything ballpark plus or minus around there. Basically, you don't need the 10-inch needle for the 3-year-old. So drawbacks, needle decompression, they are prone to kinking. They may not completely relieve tension pneumothorax, and you can't create a negative pressure. You can only create atmospheric pressure. Um, they'll also often require re-decompression, and that happens a lot. And we'll talk about that in a minute. And then, you know, The morbidity and mortality of this procedure is related to the experience and training of a clinician, right? The indication of replacement and the circumstance in which it was placed in general. You know, there can be a lot of complications. There can be malposition. There can be infection, so like an empyema or pneumo. You can have intercostal nerve or artery damage. You can have organ injury from the lung, diaphragm, heart, liver, spleen, anything of those. You can get pulmonary edema related to the re-expansion. So that's called re-expansion pulmonary edema. You can look that up if you want. And then like when it comes to like chest tubes and stuff like that, you can get like catheter malposition and stuff like that. Um, we can use finger thoracostomy as an alternative, or at least some agencies can. And then since the finger has to enter the pleural space, the finger thoracostomy has a better chance of pleural decompression with less risk of lung injury compared to a needle thoracostomy, right? Because you're physically just putting your finger in that space, not a sharp object. Looking at a systemic review of 19 studies, mortality was similar for both the finger and needle technique. Patients who received the finger thoracostomy, however, had fewer procedural complications, a higher rate of pleural cavity access, and a better rate of vital signs improvement. So basically, I found the finger thoracostomies were probably better than needles, with little asterisks that greater training is needed, and then it's obviously a higher risk of provider injury by shoving your finger into potentially broken bones. And you can have tube thoracostomy as a chest tube, and then that would generally connect to a chest drain. If you look at a chest drain, here is an atrium, which is probably the most popular form of chest drain. This is a dry seal atrium. There's not a liquid chamber here. It's like a little dry chamber here. Basically, all this is these three bottles, this bottle system, like here, just in one unit. All it's doing is, here's the patient. You're pulling fluid. There's a water seal, and then a suction seal. And that's all it's really doing. You get water fluid collection, water seal, suction control. All right, so back to the case. So we have Tom here. He has a tension pneumothorax. He's short of breath, increased work of breathing, chest wall injury, has decreased left chest wall movement. He has no lung sounds on the left side. He's tachy, he's hypotensive, he's hypoxic. What do you want to do? Throw him on O2, sure. But really, what we need to do is we need to perform a needle thoracostomy. We need to do a needle decompression. So you dart him, you hear the rush of air, he begins to improve. You place him on O2, immediately begin transporting. You have an approximately 30-minute transport to the hospital, and suddenly, about 3 minutes out, he begins having shortness of breath, tachycardia, hypotension. Basically, he's retensioning, right? So now what? Dart him again, right? It's okay to do this more than once. Usually it needs to happen more than once if you have longer transports. Don't be afraid to do it. Just go lateral to wherever you placed your first one. Usually like a centimeter, like a finger breadth away from the first one. Just go right next to it. Easy. So the second decompression works too. He improves, and by the time you get him to the ER, he was doing okay, but he still needs a chest tube. He gets one of those. He's admitted for a few days, and then the tube. Soon the tube comes out. He's discharged with pain meds for the management of his fractures, and he's doing well. And that's it for today. Thanks for tuning in. Feel free to leave questions and comments, and I'll try to respond to them soon. But until next time, thanks for watching.